This recorded lecture will be going over Chapter 30, The Child with a Skin Condition. Figure 30.1 on page 700 depicts the structures of the skin and how they differ in the developing child and the adult. At birth, the skin is thinner than the skin of an adult. Certain skin conditions in children may be associated with age, as in the case of milia in infants and acne in adolescents. Hair is inspected for color, texture, quality, distribution, and elasticity. The nurse should describe the lesions with regard to size, color, configuration, presence of pain or itching, distribution, and whether the rash is general or local. Many childhood infectious diseases like measles, German measles, and chickenpox will involve the presence of an exanthem or a skin rash. Box 30.1 on page 701 will identify terms used to describe some of the conditions of the skin that nurses could witness. A strawberry nevus, shown in figure 30.3 on page 701, is a common hemangioma that may not become apparent for a few weeks after birth. It is harmless and usually disappears without treatment. The lesions will gradually blanch, with 60% disappearing spontaneously by the time the child is 5 years of age and 90% disappearing by 9 years of age. Port wine nevi, which can be seen in figure 30.4 on page 702, are present at birth and are caused by dilated dermal capillaries. On page 702, you can read about some different skin manifestations of illness, including café au lait macules, hypopigmented macules, a butterfly rash, scaling skin eruption, and vascular birthmarks. Malaria, or a prickly heat, refers to a rash caused by excess body heat and moisture. You can see a good picture of this in figure 30.5 on page 702. It'll typically be accompanied by pruritus. This can be seen in infants during hot weather or in newborns who sleep in overheated rooms. It often occurs in the diaper area or in the folds of the skin where moisture accumulates. This harmless condition may be reversed by removing extra clothing, bathing, skin care, and frequent diaper changes. Intertrigo is the medical term for chafing. It is a dermatitis that occurs in the folds of the skin. You can see this in figure 30.6 on page 703. Urine, feces, heat, and moisture will aggravate this condition. Prevention will consist of keeping the affected areas clean and dry. Maceration of the skin could lead to a secondary infection. Seborrheic dermatitis is an inflammation of the skin involving the sebaceous glands. You can see a picture of this in figure 30.7 on page 703. Thick, yellow, oily, adherent, crust-like scales on the scalp and forehead will characterize this condition. It can be seen in newborns, in infants, and at puberty. Seborrhea resembles eczema, but it usually does not itch, and there is a negative family history. Treatment will consist of shampooing with a non-medicated shampoo on a regular basis. The nurse should teach the parents how to shampoo an infant's head using the football hold. Response to therapy will typically be rapid. Diaper dermatitis, or a diaper rash, is a commonly seen condition that results from prolonged contact of the skin to a mixture of urine and feces. The rash of a simple diaper dermatitis may appear as erythema. However, a beefy red rash in the diaper area could indicate a candida infection and necessitates prompt treatment. You can see a picture of this in figure 30.8 on page 703. It is easier to prevent diaper rash than it is to cure it. Prevention is accomplished by frequent diaper changes to limit the skin's exposure to moisture. The use of corticosteroid ointments in an occluded diaper area should be avoided because skin absorption could cause systemic complications. Acne is an inflammation of the sebaceous glands and hair follicles in the skin. You can see a picture of this in figure 30.9 on page 704. The principal lesions include comedones, papules, and nodulocystic growths. The process of development will occur no matter how carefully the teenager washes, because surface bacteria are not involved in pathogenesis. Acne is typically seen on the chin, the cheeks, and the forehead, and it is usually more severe in winter. A regular, well-balanced diet is encouraged. Routine skin cleansing with any mild soap or astringent cleanser is helpful. Squeezing pimples will rupture the intact lesions and cause local inflammation and possible infection. Medications can be prescribed, including retinoids. Topical clindamycin antibiotic may be prescribed for inflammatory acne. Systemic antibiotics like tetracycline may be prescribed for inflammatory acne as well. Acne will be very distressing to the adolescent. Drug-induced acne could occur in children taking long-term steroids, phenobarbital, phenytoin, lithium, vitamin B12, or medications containing iodides or bromides. Herpes simplex type 1 is a viral infection commonly known as a cold sore or fever blister. Recurrence is common because the virus will lie dormant in the body until it is activated by stress, sun exposure, menstruation, fever, and other causes. Herpes can be serious in newborns and in patients who are immunocompromised. Topical acyclovir or oral famciclovir or valacyclovir could reduce the viral shedding and hasten healing. Patients should be encouraged not to share lipstick and should avoid kissing while lesions are active. Infantile eczema or atopic dermatitis is an inflammation of generally hypersensitive skin. You can see a picture of this in figure 30.11 on page 705. It seems to follow a definite familial history of allergies and asthma. Symptoms will be triggered but not caused by substances that enter the body via the digestive tract, by inhalation, by direct contact, or by injections. This is more common during the first 2 years of the infant's life. Eczema will be worse in the winter and will have periods of temporary remission. Infants and children with eczema should not be exposed to adults with cold sores because the children could develop a systemic reaction with a high fever and multiple vesicles on the eczematous skin. Often a food allergy is thought to be the cause or trigger of atopic dermatitis in infants and children. Infants with moderate risk for eczema should have peanut-containing foods at 6 months of age. And infants with more severe types of atopic dermatitis should have peanut-containing foods in the first year of life under the supervision of an allergist. Treatment of the child with infantile eczema is aimed at relieving pruritus, hydrating and lubricating the skin, relieving inflammation, and preventing infection. Whenever possible, patients should be treated at home because of the danger of infection in the hospital. Corticosteroids can be administered systemically or locally, but they may be monitored for side effects like skin atrophy and systemic effects like adrenal suppression. Antibiotics may be needed if an infection is present. Systemic corticosteroids should not be routinely used, as this treatment could be followed by a flare-up of atopic dermatitis when the dose is tapered or discontinued. Avoiding irritants and identifying environmental food triggers to inflammation for the individual child are essential factors for the management of atopic dermatitis. Techniques of home bathing or the application of soaks combined with quiet playtime can enhance family coping. Controlling of itching is essential. The types of topical medications that can be used are listed in Table 30.1 on page 707. Most skin lesions will cause psychological stress, which should be addressed with both the parents and the child. Parents should be advised of changes to expect and when to seek follow-up advice. The nurse should teach parents the principles and techniques of applying a topical medication. You can see these on this slide as well as on page 707 in the bulleted list. Skin infections may occur if the number of organisms increases in preterm infants and newborns and whose general resistance is low. Primary infection of the newborn with staphylococcal infection could develop in the umbilicus or the circumcision wound. This infection will typically spread readily from one infant to another. Antibiotics effective against the appropriate strain of Staphylococcus should be administered. Ointments can be locally applied. Scalded skin syndrome is caused by Staphylococcus aureus. The lesions begin with a mild erythema that has a sandpaper texture. Vesicles will appear and rupture, and peeling occurs, exposing a bright red surface. IV antibiotics, strict isolation, and prevention of secondary infection are priorities. Impetigo is an infectious disease of the skin caused by Staphylococci or by group A beta hemolytic streptococci. The newborn is susceptible to this infection because resistance to skin bacteria is low. Impetigo tends to spread from one area of skin to another, and it is contagious. The first symptoms of a bullous lesion are red papules. You can see a picture of this in figure 30.12 on page 708. The lesions could occur anywhere, but are most often found around the nose and mouth and in moist areas of the body, like creases of the neck, the axilla, and the groin. Systemic antibiotics are administered either orally or parenterally. The prognosis with proper treatment is good. Nursing care consists primarily of preventing this disease. Fungal infections are caused by several closely related fungi that have a preference for invading the stratum corneum, the hair, and the nails. Tinea capitis is seen in school-aged children. Patches of alopecia will characterize this condition. This condition will be treated with griosufulvin, which is administered by mouth. Treatment with this may be necessary for 8 to 12 weeks. Tinea corporis is evident as an oval, scaly, inflamed ring with a clear center. Treatment consists of a local application of an antifungal preparation like clotrimazole for 2 to 4 weeks. Tinea pedis refers to athlete's foot. It occurs more often in pre-adolescence and adolescence. Treatment consists of topical therapy with an antibacterial or antifungal preparation like iconazole or cyclopyrox. The feet should be carefully dried, especially between the toes. Tinea cruris affects the groin area and is commonly referred to as jock itch. The infestation of humans by lice is termed pediculosis. There are 3 different types. Severe itching in the affected area is the main symptom. In all cases, treatment is aimed at ridding the patient of the parasite, treating the excoriated skin, and preventing the infestation of others. The most common form seen in children is head lice. Pediculosis capitis, which is commonly known as head lice, will affect the scalp and hair. It is easily transferred from one child to another and is seen most often in the school-aged child and in preschool children who attend daycare centers. Children with pediculosis capitis suffer from severe itching of the scalp. Treatment will be directed towards killing the lice, getting rid of the nits, and managing any infections of the face and scalp. Nits on the head will be removed by combing the hair with a fine-tooth comb, dipped in a 1-to-1 solution of white vinegar and water. Children should be cautioned against swapping caps, headscarves, and combs. Hairstyle trends such as tight braiding, tight ponytails, multiple ponytails, the use of extensions, and hair twisting all contribute to traction alopecia. This is a thinning caused by chronic pulling or twisting of the hair. Scabies is a parasitic infection caused by the itch mite, Sarcopetes scabi. Itching is intense, especially at night. It thrives in moist body folds, but in young children the lesions may appear on the head, the palms, and the soles of the feet. Treatment consists of application of permethrin. It can be used in children older than 2 months of age. Linen and other clothes should be washed and dried in high heat. Stuffed toys and non-washable items should be stored in bags for 1 week before use. Burns often occur during childhood. The 2 times of day which burns are most likely to occur are the early morning hours before parents awaken and after school. A child responds to burns differently than an adult does. The child's skin is thinner than that of the adult, leading to a more serious depth of burn with lower temperatures and shorter exposure. The large body surface area of the child results in greater fluid, electrolyte, and heat loss. Immature response systems in young children can cause shock and heart failure. The increased BMR of a child will result in an increased protein and calorie need. Less muscle and fat in the body will result in protein and caloric deficiencies when oral intake is limited. The skin is more elastic in children, causing pulling on the scarring areas and resulting in formation of a larger scar. The immature immune system will predispose the child to developing infections that complicate burn treatment, and the prolonged immobilization and treatment required for burns will adversely affect growth and development. The severity of a burn will depend on the area, extent, and depth of involvement. Age-related charts will be used for children to calculate the total body surface area burned because their body proportions will differ from those of adults, and a standard rule of nines cannot be applied. You can see a good depiction of this on page 711 within figure 30.15. Table 30.3 will discuss the children's responses to burn injuries on page 712. A useful rapid estimation of the body surface area involved in an infant or child with a burn is the rule of palm. This measurement is of the area between the crease of the skin at the wrist to the crease at the beginning of the fingers in the palm of the hand. We will treat burns with the 6 C's of burn care: clothing, cooling, cleaning, chemoprophylaxis, covering, and comforting. When electricity is the cause of the injury, the child should be assessed for entry and exit lesions that may appear as a small erythematous area. Emergency care of the burn includes evaluating the injury, covering the burn, and transporting to a hospital. Minor burns can be treated at home and followed with clinic visits until the healing is complete. Priorities in major burns include establishing an airway in patients with facial burns or smoke inhalation, instituting IV lines, assessing burn wounds, and other, perhaps initially unrecognized injuries. Cyanosis, singed nasal hairs, charred lips, and stridor are all indications that flames may have been inhaled. Urine output should be observed hourly. It can vary considerably, but on average, 20 to 30 mLs per hour for patients older than 2 years of age is considered adequate during the resuscitative stage. The goals of wound care include the removal of necrotic tissue to allow healing to take place, the maintenance of moist conditions and adequate circulation, the conservation of body heat and fluids, the prevention of infection, and the minimization of scar formation. When the wound is being dressed, no 2 burn surfaces should touch. The burn area should be closed and resurfaced by grafting. Temporary grafts can be used during the acute stage of recovery. This would include homografts, heterografts, and xenografts. There are 2 types of permanent grafts. These are autografts and isografts. Newly grafted areas should be covered with sterile dressings. Every effort should be made to prevent bleeding and infection. Biological dressings could be applied to a non-infected burn wound within 6 hours of injury and will peel off as the wound heals. Dressing changes will not be necessary. Vacuum-assisted wound closure is negative pressure applied to a wound after the wound has been packed and sealed. This is used in older children and adolescents, but the FDA has not yet approved the device for use with young children. Box 30.2 on page 715 will list some of the topical agents that we can use to treat burn patients. Protective isolation is instituted. The nurse should immediately report any signs of infection. The nurse remains alert for signs of fluid overload, in particular behavioral changes and altered sensorium. Frequent feedings of food high in calories, protein, and iron are therefore necessary. The nurse bears in mind that other unaffected parts of the body will still need exercise and proper positioning to prevent painful contractures. The child should begin to ambulate as soon as possible. Nurses should encourage children to express their feelings. Analgesics should be administered before painful procedures. Nurses can give constant support to parents who usually feel guilty if the child was injured in an accident. Small infants have less melanin to protect their skin and the need to be protected from sun exposure. Goals of treatment include stopping sun exposure, treating the inflammation, and rehydrating the skin. Education is the key to preventing sunburn. Physical sunscreens that contain a cream, like zinc oxide, magnesium dioxide, or titanium dioxide, will block UV light and are usually referred to as sunblocks. Chemical sunscreens that contain para-aminobenzoic acid, avobenzone, and ecamsule absorb UVB and UVA wavelengths and are typically labeled as broad-spectrum protection. Minimum SPF protection should be 30. Sunscreen should be worn whenever outdoors, even when the sun is not shining brightly, and reapplied every 2 hours while swimming. Frostbite is the result of freezing of a body part. Chilblain is a cold injury with erythema and the formation of vesicles and ulcerative lesions that occur as a result of vasoconstriction. Education to prevent cold injury is essential for those living in or visiting cold climates. Frostbitten extremities will appear pale and hard and are without sensation. Pain relief and monitoring of vital signs will be essential. Skin damage is similar to that is incurred with burns.